Good morning and welcome to Grand Rounds, everyone. My name is Hippolytus Kolofonos. I'm an assistant professor in the Center for Social Medicine and the Psychiatry Department, as well as an attending psychiatrist at the West LA VA. And it's a real honor to be introducing our Grand Rounds speaker today, partly because she has been a mentor for me since I was a student and trainee, and her work and example have really played a large role in my own choice of psychiatry as a specialty. She's a psychiatrist and anthropologist who received her MD and PhD at Yale and her residency training at NYU. She has recently joined us here at UCLA as professor and chair of the research theme in translational social science and health equity, and associate director of the Center for Social Medicine. She's co-editor of the New England Journal of Medicine case series in social medicine, and she has published widely in clinical and social science journals ranging from JAMA and the New England Journal to social science and medicine and medical anthropology on topics ranging from faith healing of addiction in Puerto Rico, psychiatric disability under welfare reform, opioids and race, and ethnic marketing of pharmaceuticals. She's also played a leading role in the development of the concept of structural competency that calls for a new approach to the relationships among race, class, and symptom expression in medical research, education, and practice. Today, she's going to share some of her work with us in a talk entitled From Racial Capitalism to Social Technologies in Psychiatry. Please join me in welcoming Dr. Helena Hansen.
Thank you so much, Ippy, for that generous introduction. Let me share my screen. Okay, are you seeing my screen pretty well? Great. Okay, so I want to thank you, Ippy, and also the Grand Rounds Committee for inviting me to speak. I especially thank this department for paving the way for me to join the UCLA Psychiatry and Semel faculty. I'm really thrilled to be working with such a distinguished group of researchers, educators, and practitioners, real leaders in psychiatry. So I'll start off by just reminding you that I'm an addiction psychiatrist and also a cultural anthropologist. So my approach today is going to be perhaps a little different than the norm for Grand Rounds. The connecting thread of my work has been a dual focus on the institutional logics shaping health inequalities on one hand, which I call structural drivers of health inequalities, and also on the other hand, a focus on community-based social approaches to promoting health, what I call social technologies. So that's just an explanation of my title. Today, I'm going to start off with findings from my forthcoming book with the University of California Press entitled Whiteout: How Structural Capitalism Changed the Color of Heroin in America. And that's going to provide an example of how I study structural racism as built into the logic of our healthcare institutions and drug policies. And also an example of how structural racism ends up harming white Americans, along with many others. So I'm going to end with work that I've been doing to promote an approach to clinical training and practice that I call structural competency, which directs practitioners to intervene on harmful policies and institutions above the level of individual patients, and also to engage with communities to foster social technologies that promote health. So I've been studying the intersection of race with the opioid crisis and the growing field of addiction medicine for over a decade. And I started at a time when the media was publishing stories about the surprise of white, suburban, and rural opioid addiction. Since that time, unfortunately, the plot has only thickened. Overdose deaths in the US have increased by more than 40% since the onset of COVID. The overdose rate has gone up fastest among Black residents in Western and Southern states, particularly California, with Black people in California overdosing 30% more often than white people. These are statistics actually taken from a study led by one of our UCLA graduate students, MD PhD students, Joe Friedman. But he's found this reversal in the racial profile of overdose in the country. So our overdose policy response in the US moving forward is now going to be even more clearly framed as a racial justice issue. So I want to put that on the table. But what makes the overdose crisis of the last 20 years different in many people's minds is, of course, the way that the white identity of sufferers has been highlighted in media and policy. So today I'm going to approach race and health from an angle that's unusual in medicine by examining the mechanisms of whiteness underlying our practice. I'm going to share a case study of the hidden yet active maintenance of white exclusivity in medicine as a cause of what we often refer to as quote unquote health disparities among quote unquote underserved minorities. So groups typically described in a passive manner as lacking access to care, when in fact, whiteness is central to our environment of profit motives, commodification, and the use of racial hierarchies to segment and open markets. So it involves the mutual racialization of drugs and people. So drugs can be white, as in targeted to white people, and they can pharmaceutically enhance the whiteness of people whose privilege is in question because of stigmatizing diagnoses like addiction. So I first encountered office-based medication for opioid dependence in the late 1990s as a medical student working on the early clinical trials of buprenorphine, which would later be manufactured with naloxone under the commercial name Suboxone. And my attendings were excited about buprenorphine at that time. They said it was about to change the culture of medicine by defining addiction as a chronic disease treatable alongside diabetes, hypertension, and asthma in the same clinics with primary care clinics, and in the same way with pharmaceutical maintenance. And of course, this caught my ear as an MD PhD student cross-training in cultural anthropology, because I had to ask, what could it mean to change the culture of medicine? And what would drive such a change? So as it turns out, my attendings were right. In the course of my career, I've witnessed a profound change in the way that clinicians frame addiction. So my field of addiction treatment swang from a quote unquote drug-free philosophy in the early 1990s to opioid maintenance as first line of treatment by the 2000s. And as I completed an addiction fellowship and took a faculty position in psychiatry and anthropology, I also documented stark differences between buprenorphine patients and methadone patients by race and class. So what began as a study of the culture of medicine became a study of how the opioid crisis came to be seen as white. Ironically, at the same time that racially targeted drug war policies led to mass incarceration of Black and Latinx Americans, giving the US the highest incarceration rate in the world. So today I'm going to give you an analysis from my forthcoming book on opioids and race based on research supported by NIDA, the Robert Wood Johnson Foundation, the American Psychiatric Association, and the New York State Office of Mental Health. So while narcotics have long been criminalized through association with marginalized racial groups, such as turn of the century images of Chinese opium dens, Negro cocaine fiends in the South, and Mexican marijuana madness, we don't often look at how symbolic association with white middle-class markets has legitimated widespread prescription of narcotics, including post-World War II epidemic overdose from barbiturates and benzodiazepines that haunted white middle-class America. We rarely ask how a drug can assume whiteness within a pharmaceutical logic based on race. And yet this process of pharmaceutical whiteness is at the core of the widely asked question, why is the life expectancy of white Americans suddenly falling while the life expectancy of almost every other racial group is rising? And how did overdose become their primary immediate cause of excess death? So to answer this, I want to go beyond the received wisdom that unemployed whites in the post-industrial Rust Belt turned to opioids for solace. So that may be true, but it begs the question, why opioids, why white Americans, and why now? So I'm going to argue that the current generation of opioids were designed to have white racial identities, and that in our stratified healthcare and justice systems, the social technologies shaping opioid consumption reinforce racial inequalities, while at the same time harming white people. And key to this story is an unrecognized form of ethnic marketing that, because it targets white people, works by not marking itself as racial. The story is invisible by design. It was only through years of observation and interviews with key actors that I've been able to unravel the threads. I've observed drug policy and addiction science meetings and clinical interactions over really a decade, and interviewed almost 200 addiction scientists, treatment advocates, pharmaceutical executives, policymakers, administrators, prescribers, and patients. So let's start where I started this study with Suboxone, otherwise known as buprenorphine. It's easiest to see its racial identity by comparing it to its predecessor, methadone. Here's a bar graph from the first and last nationally representative study to compare buprenorphine patients to methadone patients by race and class. And while I was at NYU, I mapped where New Yorkers prescribed buprenorphine versus prescribed methadone lived and found very similar distribution. So David Schreiger, my new colleague here at UCLA in the emergency department, just shared with me his map of buprenorphine in Los Angeles, showing that neighborhoods with the best access to buprenorphine are those with the lowest overdose rate, actually, for instance, in Malibu. And those with the highest overdose rates, those neighborhoods with the highest overdose rates have almost no access to buprenorphine, such as South Central LA. Recent national studies have confirmed that white Americans with opioid use disorder are 3 to 4 times as likely to get buprenorphine as Black Americans with opioid use disorder, with most patients paying for buprenorphine privately out of pocket, followed by private insurance. So this is very expensive medication. So that says something about the income and socioeconomic status of the users. Many fewer use Medicaid or Medicare. But what we don't know from graphs like this is, by what processes did buprenorphine and methadone gain their racial identities? So for this, we have to go back in history. Let's go back to 1965. Race riots have burned through Harlem, Philadelphia, and Watts, Los Angeles. The unemployment rate for Blacks is twice that of whites, and organized crime gains control of Asian heroin imports, recruiting a sales force of Black and Latinx inner city workers. Meanwhile, Rockefeller University metabolic researcher Vincent Dole, who thinks of heroin addiction as opiate receptor deficiency analogous to insulin deficiency and diabetes, publishes findings from the first clinical trial of methadone maintenance for heroin dependence. The study subjects are African-American heroin injecting men from Harlem, and its outcomes of decreased arrest and criminal activity, as well as increased employment at 6 months, brings it national attention. By 1970, news of methadone as a pharmacological answer to urban heroin reaches President Nixon, who appoints pioneering methadone psychiatrist Jerome Jaffe as the nation's first drug czar. So Nixon targets inner city Black and Latinx Americans, as well as returning Vietnam veterans, with methadone, his major weapon in the war on drugs. To prevent diversion and street sale of methadone, the DEA regulates methadone clinics, requiring direct daily observed dosing and regular urine testing. Due to community resistance, the clinics are located in marginalized neighborhoods in the city, remote from other medical services. So now we're going to fast forward to October 8th, 2002. A new kind of opioid problem has developed following Purdue Pharmaceuticals' aggressive marketing of OxyContin as a minimally addictive pain reliever. And most of these newly dependent people are white, many of them middle to upper income. The FDA has just approved the synthetic opiate buprenorphine, commercially packaged with naloxone or Suboxone, for maintenance treatment of opiate dependence in buprenorphine certified doctors' offices. So pharmacologically similar to methadone in that it blocks opiate receptors in the brains of addicted patients, buprenorphine can be prescribed monthly for use at home, while methadone is still restricted to DEA-regulated clinics and directly observed dosing. Office-based buprenorphine represents a reversal of national policy. It's the first time since the 1914 Harrison Act that private doctors are allowed to use opioids to treat opiate dependence. So to accomplish this, the manufacturers of buprenorphine and the architects of buprenorphine policy had to distinguish buprenorphine symbolically and spatially from methadone. So buprenorphine, pharmacologically in the same drug class as methadone, in that it's an opioid, had to be whitened. So this is Mike in an internet ad for Suboxone. He's seated in his Ohio diner, flanked by American flags, talking of returning to coaching his son's baseball team and singing in his church choir after buprenorphine rescued him from a prescription opioid habit following a back injury in his diner. So the coding, the racial and class coding in this ad is really unique. It represents a big departure from the race and class associations that historically we've had with addiction and opioid use. But I want to argue that this ad is just the tip of the iceberg. It's the whiteness of buprenorphine that the whiteness of buprenorphine was actively achieved by specific social technologies. And I'm going to give you an analysis of the contemporary white opioid crisis in terms of what I call technologies of whiteness. That is, social technologies of neuroscientific metaphors, policy, and industry strategies that maintain racial boundaries around biomedical uses of opioids. And this scheme is informed by whiteness studies, which is an offshoot of critical race theory. And it proposes that one, whiteness is a category of exclusion and therefore requires cultural and political maintenance of its boundaries, as in this person is white, this person is not, and these are the resources and goods afforded to people who are white. So number two, white race is unmarked. It's the assumed norm in the United States. It's rarely explicitly named, either in public policies or in the media. So the coverage of whiteness in presidential politics, as well as opioid deaths of the past 4 years, has been the exception that proves the rule. And I discovered the ways that when white race is being signaled in the recent policy debates and in humanizing media coverage of the quote unquote new face of addiction, it's actually signaled using coded language such as suburban rather than the word white. While the race of Black or Latinx people with substance use disorder continues to be mentioned explicitly, most often in relation to drug-related crime. So 3, whiteness is defined by its other. White on one hand and Black or non-white on the other hand are interdependent. Punitive American drug policy has long had a mutually defining twin of legal narcotics for white people who've had access to personal doctors, starting with morphine and over-the-counter heroin for middle-class Victorian housewives, then moving to post-World War II barbiturates, stimulant diet pills, and Valium, otherwise known as Mother's Little Helper, and now back to prescription opioid pain relievers. So lastly, white privilege has its costs. Not only do white consumers pay inflated prices for patented prescription opioids, but they also pay with their lives in the form of overdose by lethal substances to which they have quote unquote privileged access. So the 4 technologies of whiteness I'll be discussing include addiction, neuroscience, new biotechnologies, regulation, and marketing. And I'll start with the least visible technology of race making, which is that of brain science. We should put buprenorphine development and extended release opioid pain reliever development on the background of President Bush I's decade of the brain. So this was an era in which NIDA was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project. This was in the 1990s. In the process, NIDA renamed addiction a quote unquote chronic relapsing brain disease. And this was supported by leading NIDA researchers who co-authored this widely cited article in JAMA in 2000, the end of the decade of the brain. In it, they argued that narcotics dependence is comparable to diabetes, hypertension, and asthma in terms of its heritability, treatment, adherence, and relapse rates. And as such, it should be treated as a chronic medical disease. The scientists involved in this movement had a clear social justice intent. They wanted to destigmatize addiction by demonstrating that it's a legitimate biological condition and not a problem of morality or choice. But what they didn't anticipate was that the scientific universalism that they employed, because it implied a standard white male subject, would help open white markets to new opioids, and that the unequal ways that biotechnologies are disseminated would enhance the social stratification of addiction. So for instance, brain images like this, by taking out the subject and his or her trappings of gender, race, or class out of the picture, by taking the offending organ, the brain itself, out of the body altogether, the image symbolically conveys an unmarked universality of addiction physiology. Neuroscientists further reduced causation of addiction to molecular action at neuroreceptors, the ultimate disembodiment of addiction. So the apparent universality of this molecular model implies an assumed white norm. It takes a problem long associated with Black and brown crime and gives it a new implicit association with white people. In the process, however, it excludes social conditions. The scientists involved wanted to counteract a drug war mentality by erasing the social context of drug use, but they paradoxically set the stage for renewed racial stratification of opioids. So the next technology of whiteness is new biotechnologies. And here I explain that the neuroscientists that I just described unwittingly aided corporate strategists that capitalized on this erasure of the social. So building on the neuroscientists' ideology of technological solutions to addiction, in 1996, Purdue Pharma got FDA approval for OxyContin as a minimally addictive opioid pain reliever suitable for chronic management of moderate pain. And this was based on its patented sustained release capsule technology, which in theory lowered the reward for users by preventing an initial rush. The manufacturer influenced the National Joint Commission on Hospital Accreditation to call for pain to be aggressively monitored and treated as the fifth vital sign, along with respiration, heart rate, blood pressure. And drug reps who canvassed prescribers advised new opioid prescribers to direct OxyContin to quote unquote trustworthy patients as an additional safeguard. So the term trustworthy in a national clinical workforce that's been shown many times to suspect non-white patients of drug abuse, the word trustworthy itself implied white patients. Of course, what the model of addiction-proof biotechnology left out was the social inventiveness of drug use. So OxyContin users interested in a rush quickly learned to crush and snort or inject the oxycodone in each capsule. And after steep increases in opioid, non-medical opioid use and overdose, public pressure mounted for intervention. So in August of 2010, just as the original patent of OxyContin was running out, Purdue Pharma introduced its tamper-resistant time-release formulation, embedding oxycodone into polymers that convert tablets into gummies should users attempt to crush and dissolve them in order to inject them. By keeping prices high and representing OxyContin as technologically sealed off from misuse, the manufacturer strove to keep OxyContin symbolically a step ahead of urban and code word for non-white street markets. Another biotechnology developed specifically in response to the white suburban and rural prescription opioid epidemic is buprenorphine itself, combined with opioid antagonist naloxone and branded Suboxone. So Reckitt Benckiser Pharma promoted this combination as a smart drug. Although buprenorphine it can be misused as an opioid, used non-medically as an opioid, the naloxone with which it's combined causes withdrawal symptoms if injected, but not if dissolved under the tongue as prescribed, since naloxone can't be absorbed sublingually. Buprenorphine also posed a lower overdose death risk than other opioids. So in the 1990s, NIDA subsidized Suboxone manufacturer with $23 million to test it for use in addiction treatment and sharply distinguished it from methadone, lobbying Congress and the DEA to lower the abuse potential rating of Suboxone from narcotic schedule 2, where OxyContin and methadone fall, to narcotic schedule 3, along with codeine cough syrup. And this is what made it possible to prescribe Suboxone in private doctors' offices. The manufacturer also lobbied Congress to get Suboxone included under an orphan drug designation clause designed to promote pharmaceutical development for unprofitable diseases in low-income countries, like malaria drugs. Suboxone's designation got it a patent extension through 2009 on a drug initially developed in the late 60s. In a race and class stratified healthcare system, such as we have in the US, where access to general doctors is often limited to those who can pay, patented, expensive technologies for private office delivery in themselves encode white race and middle class. So the third technology of whiteness is regulation. Although by 2004, prescription opioids overtook heroin as the primary opiate of abuse in the US, the arrest rate for their illegal possession was 1/4 that of the arrest for possession of heroin. And arrest for illegal sale of prescription drugs was less than 1/5 that of arrest for selling heroin. Not coincidentally, the non-medical use of pain relievers was twice as high among white Americans as Black Americans at that time, while rates of heroin use among Black, Latinx, and white Americans were almost identical. Since suburban and rural white opioid users were not politically popular targets for drug law enforcement, the DEA and other regulators focused their surveillance and enforcement on prescription opioid prescribers and pharmacists instead. And one sign of this was the rapid spread of prescription drug monitoring programs, ultimately to all 50 states, half of which mandate prescriber participation with threats of loss of license and prosecution for those prescribers who don't check their statewide database to see if the patient has been prescribed narcotics elsewhere. So returning to buprenorphine, otherwise known as Suboxone, the Drug Addiction Treatment Act passed by Congress in 2000, known as Data 2000, enabled any certified physician to prescribe Suboxone in the privacy of their own office. In congressional debates leading to passage of Data 2000, there's a clear emphasis on a quote unquote new kind of user, one that's young, suburban, and quote unquote not hardcore. So these were code words for white. Recorded testimony from federal officials stressed that buprenorphine was uniquely appropriate for a new kind of opioid user as opposed to methadone, quote, which tends to concentrate in urban areas and is a poor fit for the suburban spread of narcotic addiction, end of quote. Then Health and Human Services Director Donna Shalala was but one of many officials who noted that buprenorphine as an alternative to methadone would serve a quote unquote new kind of addict, quote, including citizens who would not normally be associated with the term addiction, end of quote. So with this racially coded language in which suburban and new kind of addict referred to middle-class white people, Data 2000 passed Congress and reversed 80 years of federal prohibition of private physician opioid maintenance for opioid dependence. So Data 2000 kept the restrictive methadone system intact and did nothing to alter the drug laws that mandated inner city heroin users to prison, but it did create a new treatment track for those who had the resources to use it. To give additional assurance to the DEA that buprenorphine wouldn't spill over into illicit markets, buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, developed an 8-hour certification course that was required for doctors to prescribe buprenorphine, and it was the first and the only prescription drug in the US to come with such a requirement. Public sector doctors that I interviewed told me that the certification requirement is a major barrier to making buprenorphine available to low-income people because public clinics don't provide time or incentives to pursue certification, while prescribers in the private sector can charge fees of up to $1,000 for an initial visit for buprenorphine induction. The shortage of public sector prescribers, along with the cost of buprenorphine itself, have long kept buprenorphine in the private sector. Okay, and then the last technology of whiteness is media and marketing. OxyContin's legendary commercial success hinged on its designation as minimally addictive. And when OxyContin was under review at the FDA, Purdue estimated the addictive potential of OxyContin to be less than 1% based on testing among terminally ill cancer patients for a 3-month period. In 1996, the FDA accepted this claim, enabling Purdue to open opioid markets that had previously been restricted to those with severe acute pain, like post-surgical or cancer pain. So Purdue was able to open a new, much larger market of patients with moderate chronic pain, like lower back pain, hiring almost 700 drug reps who canvassed a call list of 100,000 physicians in the first few years alone. So Purdue targeted general doctors in white, suburban, and rural areas, serving patients that the public and the DEA did not think of as at high risk for addiction and drug trade. Purdue's strategy was successful. It led to a 10-fold increase in prescription opioids nationally, with disproportionate uptake of OxyContin by prescribers in white, suburban, and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. So in a newspaper content analysis that I completed, I found that in contrast with articles about the criminality of Black and Latinx drug users, suburbanites addicted to OxyContin were portrayed sympathetically in the media as victims of overprescription or as people struggling with real or existential pain. Ironically, Purdue's technological response to the first wave of white prescription opioid overdose deaths, their tamper-resistant formulation of oxycodone, combined with new prescription drug monitoring programs, led many of these opioid users to look for heroin when pills became hard to get. And one consequence of this was a whitening of the media coverage of heroin users who'd long been portrayed as Black or brown. So this is a school teacher from upstate suburban New York. And this is a college athlete from Arizona. just two of myriad images that came out in the media around this time, the new face of heroin. The targeted intervention for these new heroin users, buprenorphine, otherwise known as Suboxone, was marketed to middle-class insured patients over the internet. So manufacturer-sponsored web-based public service announcements featured white professionals and business owners on Suboxone maintenance. And I invite you to look at the race and class coding of this webpage, which some of you may have used. Specifically, you may have directed your patients to go to the buprenorphine locator, prescriber locator service that's co-sponsored by the Substance Abuse and Mental Health Services Administration and was co-created with the manufacturer of buprenorphine, Reckitt Benckiser Pharma. If you could go to the lower left-hand corner of this website and click Patients Find a Buprenorphine Physician, put in your zip code, you'll get a printout of buprenorphine certified prescribers in your area, the vast majority of whom will be in private practice. So these strategies created an exclusive yet lucrative segment of the market for Suboxone, making it a blockbuster drug. By 2012, it was selling well over $1.5 billion in the US alone, second only in that year of 2012 to OxyContin, which reported US sales of $3 billion in that year. So to conclude, this racial segmentation of drug markets into licit and illicit, white and black, clinical and recreational, creates a moving target of time-bound patents on new technologies that target the white middle class. And this is an old cycle. It was started by Bayer Pharmaceuticals' own heroin, which was marketed as a non-addictive treatment for morphine addiction among middle-class Victorian housewives in 1898. And another indication that it was marketed for in 1898 was as a highly effective cough syrup for children. What can we learn from this as clinicians, researchers, and policymakers? Okay, so I want to posit that magic bullets are a myth, as the failed promises of OxyContin's sustained release capsule show us, and also the inability of a unilateral focus on buprenorphine treatment to stem, the inability of that alone to stem overdoses has shown, biotechnology cannot stop the harms of narcotics without systemic and social intervention. And to underscore this point, I'm going to turn to an international comparison that's often used by my colleagues in the US who are advocating for buprenorphine expansion. So in France, where buprenorphine was adopted for general physician treatment of opiate dependence in 1995, it was billed not as a stigma-reducing agent for a middle-class market, but as a public health intervention to stem overdose and HIV among low-income, largely immigrant heroin injectors. So buprenorphine was widely adopted among primary care doctors in France, all of whom were expected to use buprenorphine and none of whom were required to do a voluntary additional certification for buprenorphine prescribing, as we have in this country. So within the first 5 years of buprenorphine's introduction into general practice, the overdose rate in France dropped by 80%. And I invite you to contrast this with the US, where opioid overdoses are now well over 5 times what they were when buprenorphine was approved in 2002. And based on my interviews with white and non-white people trying to access buprenorphine and stay on buprenorphine in the US, I suggest that the public health potential of buprenorphine is limited by our race and class segregated market-driven healthcare system, in which patients that have patchy insurance coverage and tenuous access to prescribers often cannot stay, even if they can begin on buprenorphine, they cannot be maintained on buprenorphine and get the public health benefit of overdose prevention. I want to also point out that going back to France, France has a universal healthcare system and a robust social safety net. They spend twice what we spend per capita on social services. These are critical elements to their success with buprenorphine. As of the mid-1990s, France funded a network of community-based harm reduction and treatment centers for heroin injectors that provided healthcare, buprenorphine, and increasingly methadone, assistance with housing and employment, as well as clean syringes and medically supervised overdose prevention. So I want to emphasize that buprenorphine was not simply disseminated in a privatized healthcare system in France. It was actually combined with many other strategies for a much more holistic approach to opioid use disorder. And then one other point is that if you look at the slide in the upper left-hand corner, you see that at its peak, French overdose rate was 565. Okay, so that's 565 people in a country of 60 million, as opposed to the US, where it would be closer to 565,000. So in a nutshell, France did not have an overdose crisis, certainly not of the proportions that we had. Why not? In the 1990s, direct-to-consumer and direct-to-prescriber marketing of medication was illegal in France, and France had a national, and continues to have, a national drug purchasing body that independently assesses pharmaceutical company claims of clinical advantage and safety of new drugs. And its members are not allowed to have any ties with the pharmaceutical industry before, during, or after their review. Very different from our country, where, as we have read, many of the FDA officials who reviewed OxyContin got very lucrative jobs with Purdue Pharma and other extended release opioid manufacturers shortly after. But the point is, OxyContin was never marketed in France. This should make us skeptical about the power of the market to protect the public and to rectify inequalities in health. In our for-profit healthcare system, buprenorphine maintenance has followed the pattern predicted by theorists of fundamental causes of disease, Bruce Link and Joe Phelan, that new biotechnologies in a society like ours that has very large social inequalities, new biotechnologies, if social inequalities are not addressed, will only widen rather than narrow health inequalities, as opposed to what many of our biotech and pharma manufacturers advertise, that this next new technology will solve the problems of health and health inequalities. Okay, second, addiction is biosocial. We should reconsider what it means to say that substance use disorder or addiction is a chronic brain disease. Basic neuroscientists are, and what I mean by that is that we know from our practice as physicians and other clinicians that asthma, hypertension, and diabetes do not respond to medication alone. You have to address the patient's social environment for them to even use the medications adequately to address their health issues. But also, basic neuroscientists are increasingly seeing the brain as plastic, as a socially responsive organ that's evolved to adapt to complex social systems. So emerging life science models of neuroplasticity, epigenetics, and the microbiome have underscored that human biology is not a fixed entity, but it's dynamically shaped in interaction with the social environment. And these more sophisticated biological models inherently call on us to invest in research on the impact of social systems and on interventions that create healthy social contexts, including robust social services and recovery support networks that give dignity, meaning, and structure to people's lives. So if we were to take seriously, for example, the comparison of drug dependence with diabetes, asthma, and hypertension, we'd recognize the strong social determinants of diabetes, asthma, and hypertension, and that success in their treatment and prevention requires social support, access to fresh food, safe, unpolluted, walkable neighborhoods, and the list goes on. So third, deaths of despair call for racial and economic justice. So Ann Case and Angus Deaton's 2015 report on the decline in US white life expectancy was unusual in that its authors were not epidemiologists, they were economists, and their analysis of root causes of overdose, as well as suicides and cirrhosis, lay not in neuroreceptors or genetics, but in the deindustrialization of the American Rust Belt, where departure of manufacturing and mining industries left behind high unemployment and social disintegration. And a sociological study that followed that report showed overdose rates were linked to thin social networks. Accordingly, Case and Deaton have popularized the idea that overdoses are quote unquote deaths of despair. So their argument is persuasive, and it calls for social and economic revitalization through policies that promote social integration, stable employment, livable wages and benefits, not just public-private partnerships to develop, quickly approve, and disseminate new medications as are currently prioritized in the NIH HEAL initiative and the Cures Act. But Case and Deaton's focus on white Americans makes the analysis incomplete and makes Black and Latinx overdose deaths invisible. Case and Deaton don't have a clear explanation of why Black and Latinx life expectancy did not decline in the time period of their study, but I propose that Black and Latinx Americans saw an overdose crisis 30 to 40 years before the current white one. And the influx of heroin to inner city neighborhoods from the 60s to 80s drove this. Blue-collar workers in Black and Latinx neighborhoods were often barred from unions. They were the last hired, first fired, and saw massive unemployment much earlier than white workers who were initially protected by industrial discrimination. So this earlier Black and Latinx opioid crisis was not seen as a health crisis. Rather, it was reported in the popular press as an epidemic of crime, leading to white flight from cities and further disinvestment in Black and Latinx city neighborhoods. So we're left with the survivors of that earlier crisis, even as we learn that Black middle-aged men are now the group with the fastest rising overdose death rate, due largely to lower tolerance after mass incarceration and exposure to fentanyl. So incarceration is itself a risk factor for overdose. So while we work toward race and class justice and economic policy, we should use concern about the opioid crisis to go beyond drug development to invest in universal healthcare with psychosocial interventions, including trauma-informed therapy, attention to psychiatric comorbidity, peer navigation, recovery support, housing, employment, and then to divert people with opioid use disorder from criminal justice system and promote treatment and harm reduction as a national response to opioids, not through local initiatives, but nationally. And 3, public resources should be moved from drug development and a magic bullet approach to research on and implementation of innovative biosocial community-based treatment approaches, including peer-based recovery networks involving the arts, urban gardening, community organization-based interventions, including spiritual and religious organizations. And I am going to end just with a very brief review of a systematic approach to this, to addressing structural drivers of health inequalities in the opioid crisis, but also beyond that. And so this is a cover from a book that I have edited with Jonathan Metzel, my collaborator in promoting this approach, and contributors to this book are in our growing network that include Ipi Kalafnos, among many others. We have lots of partners here at UCLA and nationally who contributed to this book. I'm not going to spend time, hopefully in the discussion we can get to the distinction between structural drivers of health and social determinants. They're intimately related, but I just want to define structural competency for you because it's an approach that I'm working with colleagues here at UCLA right now to bolster. One, the term structure, which is taken from social sciences, indicates the need to shift the focus of our clinical interventions on health inequalities, not from individual patients, but to institutions, such as clinical, educational, correctional, to communities, so through community engagement, and to public policy, advocating for health promoting policy. And then second, competency indicates the need to act on the knowledge that we have about structural drivers of health, and to use our symbolic social and cultural capital as clinical practitioners to advocate for, in partnership with organizations representing patient populations, community-based organizations, to advocate for better systemic approaches. This is a list of the competencies, which we can discuss hopefully if you're interested, but I just want to quickly walk through the levels of structure that I think we need to be working on. So in-clinic structural intervention includes, for example, using electronic medical records to ask patients, to prompt practitioners to ask patients about their social needs, which has been shown to increase referral for social services, working with medical legal partnerships to intervene where that is helpful to the patient's care. So for example, with negligent landlords or landlords that are, or school systems that are in violation of the Americans with Disabilities Act. Social prescribing is an approach that's taking on popularity. So along with medication prescribing, a practitioner can prescribe assistance, for example, with applying for Social Security benefits, and then refer the patient to a volunteer organization to help with that. And then peer and community health workers, that's increasingly important in psychiatry, people with lived experience of serious psychiatric diagnosis of substance use disorder who are trained to work as a part of the clinical team and help patients navigate. And then there's collaboration with non-sector agencies like housing, legal aid, schools, cultural arts, urban planning. And then another level of structure at which we can convene is through community partnerships. And I have two specifically opioid use disorder related projects up here. On the right, you'll see Imani Breakthrough. In the center, the woman standing in the center is going to be presenting for our social medicine and theme in health inequalities and translational social science seminar series. And I invite you to come next Friday, the 23rd. Ayanna Jordan will be presenting on her research in placing addiction services in Black and Latinx churches as a way of greatly enhancing community engagement and meeting patients where they are. And then the last level of structure at which we should be intervening as clinical practitioners is in policy advocacy. We have not really used our voice up to date to do that. And I live in the world of drug policy. So the organization on the bottom, From Punishment to Public Health, is an organization that specifically gathered to divert people from incarceration towards treatment, mental health and substance use treatment systematically. And they've trained practitioners like me to testify for policymakers about, for example, the value of rescinding drug policies that mandate incarceration. And then I'll end on this slide of our website, which I invite you to visit and to join our growing network. So there are ways to register for our listserv. We have upcoming events, and we also have started posting training materials and other materials on how clinicians can intervene on structures. And with that, I'm going to end and ask if there are questions. Thank you.
Thank you very much, Helena, for that comprehensive presentation that, you really touch on so many threads that we could kind of dig into in the 10 minutes of discussion that we still have. So please, folks in the audience, please do post your questions for Helena, for Dr. Hansen, and we can address them in our discussion. One question, I actually got some questions texted to me as well. So, one sort of basic, addiction psychiatry question is and a comment that I think speaks to the whole, one of the basic messages of your talk. And the question it was, do methadone and Suboxone actually treat the same thing? And the only difference is that Suboxone is targeting white middle class and methadone targeting poor and people of color. Wow, I put them in totally different categories myself. So that's a psychiatrist questioning and commenting. So that might be a nice thing to start with.
Thank you. Yes, buprenorphine versus methadone. I attempted to illustrate in this talk how much labor has been put into distinguishing buprenorphine from methadone and really teasing out how they're not only pharmacologically different, but also that they are suitable for different populations. And I've attempted to tease out how that whole debate has been greatly distorted by the imperative in our highly racially stratified society, which has had for over a century, racialized drug policies. Prohibitionist policies that gained popular support because of widespread association with Black and brown people. Okay, so we're in a specific context. Within this context, the only way that buprenorphine's manufacturer and supporters of buprenorphine, office-based buprenorphine treatment could really get the product out to market was to explicitly cultivate a racial image, for a race and class image for buprenorphine that was different than that of methadone. Methadone carried enormous baggage. It was seen as a drug for largely Black and brown, down and out homeless people. If buprenorphine had been associated with methadone, first of all, it would not have gotten popular support, would not have gotten around the DEA regulations that would have prohibited office-based prescription, and it wouldn't have gotten market share for people who had money to pay for a newly patented drug. So I just want to highlight, this is not kind of a distant scientific question. It's actually a question that you greatly have to contextualize in our society, right? So given all those factors, if you look at the differences between buprenorphine and methadone, there are pharmacological differences, certainly. And I am a practitioner. I have treated people with both buprenorphine and methadone. I know that it's important to have both as options because some people do better with one, others do better with the other. And I can go ahead and list all of those clinical indications, but I won't spend all of my time now, other than to say that we have to, as practitioners, understand the context in which new medications are marketed and they gain personalities. Okay, so the personality of buprenorphine and for whom buprenorphine is appropriate. I came of age as an addiction psychiatrist in a moment where people were saying, no, buprenorphine is it's a light drug that's appropriate for people who have a lot of structure, who have a job. Okay, well, who is that coding for, right? And then when more detailed comparisons came into play, it was discovered that actually buprenorphine could be highly effective for people with a high opioid tolerance. It depended on the dosage and it depended on the person. So there's a lot of tailoring to individual needs to be done. And there are people who don't respond well to buprenorphine, particularly people who say that the naloxone added to buprenorphine still, even if taken sublingually, gives them withdrawal symptoms. There are people who say that they simply don't feel as good on buprenorphine as they do on methadone in terms of their opioid maintenance. So we need flexibility, right? But in our highly racial and class stratified healthcare system, we've been limited in who we can give which one. Let's just be honest about that. And it's also greatly distorts our impressions of who is appropriate for which drug. So I just want to put that out there. That's an incomplete answer, but I could go on forever with that.
Mm-hmm. And the limits, and I think, again, the limits aren't just clinical, which this psychiatrist was saying. I think of them as so differently. I think of them as treating different populations, but they're also structural, right, in terms of getting that you covered, right? So just, I guess, to reemphasize that, getting the certification, how easy it is, how hard that is, what clinics are even going to have this available, getting to those clinics. And, I think another really, I think, important and fascinating piece of your talk is in the title, I think that might bear, be nice to come back to, is the idea of racial capitalism and the how and why did this happen? Really thinking about that, and I think you pointed out the role of privatization in that process, right? And so I wonder if you could talk a little bit more about how and why this happened with opioid, in this particular case, and is this a very unique case?
I'm so glad you asked that. Okay, and I'll start with that very last comment, which is that the patterns that I'm showing for opioid medications and treatment for opioid use disorder are not unique to addiction medicine or opioids, right? So another track of research that I've had has been to look at other medications and how race plays in their development and marketing. And I'll just pull out two from psychiatry. So we know that second generation antipsychotics, the type of second generation antipsychotic that is prescribed to largely affluent white patients as opposed to Black and brown Medicaid insured patients, very different profile. So for example, Abilify was marketed to white middle class markets. It's weight neutral, quote unquote, right? It's less sedating. It's something that is good for people who want to maintain their productivity in the workplace, et cetera. And then Zyprexa, highly sedating, right? Really used very often in public hospitals where the goal is to keep people sedated and quiet, but comes with this huge risk of diabetes as well as weight gain, right? So that's just one example. And it turns out these were deliberate strategies. It also comes around to treatment for ADHD, right? If we look at who's getting newly patented stimulants for ADHD, as opposed to who's getting off-label uses of second-generation sedating antipsychotics for ADHD symptoms. And again, that's highly stratified by race and by class. And that's also the result of a deliberate marketing strategy. I want to call attention to the fact that the healthcare industries together, biotech, pharma, insurance, they make up the single largest economic sector in our country and probably worldwide. Incredibly huge engine. They have a lot of power in our country in terms of political lobby. Pair that with the fact that we have a highly, highly racialized racially stratified country, where the marketers of healthcare products are going to attend very carefully to the race and class of their markets. And so they have developed nuanced and sophisticated ways of doing that. And that's what I mean by racial capital. We are in psychiatry in the dead center of racial capitalism in healthcare. The way that we prescribe medications and the way that we think about different populations of patients, highly influenced by this dynamic. I just want to point that out. So this is not exclusive to opioids by any means. And now I've lost the thread at the beginning of your question.
Well, I think I was also asking, about the role of privatization, but I think you hit it. I think you covered it. But so another question, so there's audience members interested in hearing about kind of your reflections on, some of your past work. So you've done long-term participant observation in both Puerto Rico and its long-term inner-city diasporas on the East Coast. Can you expand more on access to treatment and the impact of big pharma and historical formations of racism and class interface in those two contexts from your clinical as well as your anthropological perspective?
Thank you for that. That gives me an opening to kind of pan out a bit and say that I've long held these two different entry points into this. So the study I just presented is really kind of a top-down look, because I did interviews and participant observation with pharma executives and neuroscientists and policymakers. But I've long been interested on the community grassroots level. How are people responding to these big structural forces? And what I'm finding is that they tend to be, as you wouldn't be surprised to hear, left out of a lot of what's happening biomedically. In Puerto Rico, for example, very little access to addiction medicine, right? So what have these communities done? They've come up with their own homegrown approaches. They have their limitations. So for example, my study of evangelical addiction ministries founded and run by self-identified former addicts who started these self-fashioned rehabilitation programs. They have their limitations, but there are also things that we can learn from them about how to marshal social techniques for managing problems like problem substance use or even psychotic disorders, other kinds of problems. What can we learn from them on that count? Because they have found some techniques that can be helpful with or without medication. And also, how can we partner with them? That's where my emphasis on community engagement comes in. And that's why I encourage everyone to attend Ayanna Jordan's talk next Friday on the 23rd from 12:30 to 2, because when you take populations like Puerto Ricans or Black Americans who have had very negative experiences in our healthcare system, particularly in mental health treatment and addiction treatment, who often encounter their first psychiatrist in a jail or in an ER where they're being very marginalized and stigmatized, they respond much better to services in trusted spaces provided by people that they know. And so Ayanna Jordan is at the forefront of a group of psychiatrists that are really trying to rethink mental health service provision so it meets people where they are. And I see that we're out of time, but I also saw, just to end on this note, there's a question about looking at class or SES rather than race when it comes to buprenorphine. And I just want to illustrate that in the social sciences, what we've come to understand is that race and class are so intimately interconnected that you have to have a much more holistic view when you ask those questions about race versus class. In many ways in our country, race signals class. We are in a country where Black Americans have less than 1/10 the wealth of white Americans. And of course, there are poor white people in the United States who actually, in terms of policy, drug policy for one, the way that they're approached, in Appalachia, for example, I have sociological colleagues who've studied the ways that they are in the media and in policy debates blackened. You know, they are spoken about and approached in a way very similar to the way that Black Americans and Latinx people are spoken about when it comes to drug policy, and they suffer much more criminalization than affluent white people. So I just want to highlight that this is where social sciences can greatly deepen our understanding of these problems. Race and class are not they're not independent of each other as variables. We're in a cultural and social system in which they're deeply interconnected, and they have to be studied that way.
Great, well, thanks. And the questions and comments keep flooding in, but I think what's amazing is Helena's here at UCLA with us. So this is beginning of a conversation that hope will be ongoing, including this Friday at 12:30 with Ayanna Jordan's talk. And people also asked in the questions where they can get to your website and sort of learn more about this. I think a lot of your papers are on your website too, right? In the links. So the structuralcompetency.org, is that the website?
Yes, that's the website for anyone who'd like to join or learn about or join our efforts to focus on structural drivers of health inequalities. And I just want to acknowledge you, Itpi, as like a core champion of this approach. I so appreciate my collaboration with you.
Well, thanks. Well, I mean, thank you for your leadership and really,
and
sort of forging this path. So, and thanks everybody for attending. We'll see you all on Friday at Ayanna Jordan's talk.